Welcome to the Global Hemophilia Report, a podcast where science meets storytelling to drive change. I'm your host, Patrick James Lynch, and this show is produced by Bloodstream Media and Believe Limited with support from our senior scientific advisor, Dr. Donna DiMichele, and is made possible thanks to our featured advertiser, Sanofi. Today, we discuss shared decision-making in the ever-evolving hemophilia treatment landscape. How do we make SDM effective and accessible? And what is the responsibility of the patient when engaging in shared decision-making? All that and a whole lot more right after this.
Sanofi seeks to break barriers for people with hemophilia through groundbreaking science so they can live beyond the limitations of their condition. Learn more about Sanofi's commitment at redefininghemophilia.com.
Hemophilia treatment has evolved dramatically, offering more options than ever before. But are patients and healthcare providers truly aligned when making decisions about care and treatment? Shared decision-making has emerged as a fundamental principle in modern hemophilia care, aiming to center the patient's lived experience and voice in therapeutic choices. But shared decision-making is not just about open dialogue. It is a structured, evidence-informed process developed by international experts through organizations like the World Federation of Hemophilia. Shared decision-making tools combine algorithmic pathways for clinicians with complementary patient preference tools, though the latter are still in development. Despite the availability of these tools, their real-world adoption remains limited. The reasons are multifactorial, ranging from underdeveloped infrastructure in low-resource settings to a lack of integration in early decision-making scenarios like newly diagnosed patients or those navigating gene therapy. This episode will explore both the philosophy and, importantly, the practical application of shared decision-making through a kitchen table science lens. We'll examine how shared decision-making is currently practiced, what tools exist to support it, and importantly, where gaps remain in truly collaborative care. As always, we are honored to be joined by our expert panelists, who will now introduce themselves, starting with Brendan.
Thank you, Patrick. I'm Brendan Hayes. I am Senior Director of Education at the National Bleeding Disorders Foundation, and I have been really honored to work with WFH on the team that created the shared decision-making tool.
So myself, let's cross the ocean. So my name is Cedric Hermans. I'm a professor of hematology. I'm based in Brussels, Belgium, where I'm heading one of the hemophilia treatment centers. But I'm also quite involved in our community, especially with the World Federation of Hemophilia, and also doing my best to support, this initiative, promoting, implementation of the SDM tool. So thank you for the invitation to join.
Thank you both for being here. And of course, as always, I'm joined by my partner and senior scientific advisor on the Global Hemophilia Report, Dr. Donna DiMichele. Good morning to you as well.
Good morning.
Mark lives with hemophilia A. Along with spending time with his wife and their twin daughters, he enjoys volunteering and cooking. What you don't know about Mark is the impact that living with hemophilia has on his daily life. Mark bravely shares how hemophilia has impacted his relationships. He emphasizes that shared decision-making with healthcare providers, along with strong family and caregiver support, is key to managing the challenges of hemophilia. Scan the QR code or click the link in the show notes to hear Mark's full story and learn more about how important shared decision-making is for hemophilia patients and their support system.
So, Brendan, let's start with you. Shared decision-making, let's not overlook just the foundational definition. What exactly is shared decision-making? And if you could, how did it come about as something we are speaking about so often these days?
Definitely. This is a concept that I think has been around for a while. I believe the motivation that we're seeing today for this to be much more in practice is gene therapy. I recall when I had attended a gene therapy conference back in, I think it was 2019. One of the physicians there and I were having a discussion, and I vividly remember him saying, this gene therapy thing is so different. I'm a little concerned. And, this isn't like a factor product that a patient could try and try something else. This is something that you can't undo. And, when I have, patients ask me, what would you do? I can't answer that question anymore because, they actually have to be involved in this decision-making process. So that's something that really resonated with me.
I think there's been a real revolution. Let's put this into perspective. Let's think about what the treatment was 15 years ago. We only had a single treatment option, which was to offer patient factor VIII, factor IX concentrate to give intravenously with 2-3 infusions per week, with the only ambition to keep the levels above 1%. So that was the goal. But clearly there was limited area for freedom. There was no real flexibility there. And honestly, I had to convince patients to do that. And most of the time I had to do that in a more or less paternalistic way, because that was the only way to convince people to do this, because it's such a burden. And now it's totally different.
I think in terms of just sort of basic explanation, the theory here is to have the patient and the physician having a conversation, a real dialogue. And it isn't just the physician telling the patient what they need to do. It isn't the patient asking for certain treatment options, but it's having a real discussion about the benefits and limitations of these various treatment options.
So the treatment landscape has nothing to do with what it used to be 20 years ago. We have multiple treatment options. That means that we have choice. We had no choice in the past. In the past, there was no choice. That was completely rigid. There was only one option, and people who could do this were quite lucky and happy they could do it. Today, we have plenty of treatment options: replacement, non-replacement, subcut, IV, cure with gene therapy, and so on. So that means that there is plenty of time, opportunities to discuss. And maybe also importantly, there is no treatment that is perfect. So this is every treatment has weakness and strengths. And that means that there is no single treatment that would fit for everyone. This is clear. So we have to adopt a new approach, which is, this share. So we need to share plenty of things with the patient, and then we need to make a decision, about what treatment should we select or go for with a specific patient.
I think that's the real benefit of shared decision making. And I think it's also really important for our physicians to understand a little bit more on a deeper level what a patient values, where they are in their life, what's important to them right now. So, for example, it could be, a young man in college who wants to be more physically active. It could be, so gene therapy could be something that would be really great for him at this point in his life. So it's understanding, what the issues are, what the concerns are from the patient perspective. And it's the physician being able to really connect with the patient and help them understand not only how these treatment options work, the mechanisms of action, but how these treatment options can connect to their values and where they are in their hemophilia journey.
It's an opportunity, but also some sort of obligation. And I'm sure we'll have plenty of time to discuss, because it's such a change in medical practice on both sides. On the patient side, many patients were not used to this. The doctors was used to tell them what to do, okay, and they had to do this. And today it's different. And for the doctor side also, they need to adopt another communication approach. So everything has changed. It's nice, but it's a bit challenging.
To Cedric's point, historically, with the doctor knowing best, right? Quote unquote, doctor knows best. Doctor says this is what's best for you. As a patient, I'm not going to lie. There's a part of me that wants that. There's a part of me that wants to walk in and say, Cedric, there's all these options. What's best for me? I don't want to have to think about it. It's too complicated. In fact, I may argue it adds to my burden as a patient that I now have to become a pseudoscientist in order to have a conversation about my treatment. Cedric, have you faced any conversations with patients who are adopting this kind of posture?
This is highly individual. That really depends on everyone, education, well, plenty of factors. So yes, it's clear that some patients really want to play an active role in that process, be involved, really be empowered. And some patients want to remain passive. They want to receive the information in a passive way and not only be dictated what to do. But I don't think this is the way to go. And honestly, and Brendan said about, especially when it comes down to critical decisions such as gene therapy, you really want to have a proactive patient in front of you. You don't want to have a passive patient. I don't want to decide for someone, my friend patient, you should go for gene therapy. I could not do that.
You used the word obligation earlier, Cedric, and it strikes me as a patient, especially if we think about therapies such as gene therapies. I have an obligation to myself to show up as well-informed as possible, because it's actually unreasonable for me to show up to the office and say, Cedric, decide for me. What's best for my life with something especially as profound as an irreversible gene therapy?
That should be a collaborative decision with both parts having his words to say at the equal level. I think this is, in my view, very important. Especially for irreversible treatments such as gene therapy. I would feel really uncomfortable for this to decide for someone to go for gene therapy. And most of my colleagues would adopt, I think, the same type of attitude.
Brendan, you worked on the development of this shared decision-making tool through the WFH, and I understand that there were numerous perspectives, numerous stakeholders whose input went into the creation of this tool. Can you speak to the stakeholders that helped inform this tool? And then importantly, what perspectives were left out?
Oftentimes, organizations or nonprofit organizations are out running around doing their own thing. They get a charge to do X, Y, and Z. Go create a shared decision-making tool. So that's something that I was tasked with as part of the Innovative Therapies curriculum. And, doing research, I discovered that WFH was actually doing this as well. It made no sense for NHF at the time and BDF to do the same thing. And so we partnered with WFH on this activity, and really proud of what we were able to accomplish. I can't stress how much time and attention was given to this tool. This was a multi-year process.
It's quite ambitious, because it's totally different from what we used to do in the past. So it's really implementing a new way of running clinics and things like that. So it's not that easy.
Different stakeholders were pulled in. So we had lived experience experts, patients. We had physicians. I believe nurses were involved, nonprofit organization, patient advocates. So we had a lot of different people trying to not only come up with what should be included in the tool, how the tool should function, et cetera. So we spent a lot of time, had lots of meetings to come together to figure that out. Once we hammered out what we thought was important, based on that initial committee, we broadened it to pull in many others. So we did a rollout of the tool to several different groups and took the feedback from those groups and ended up, perfecting the tool, so to speak.
And I think this kind of activity webinar today is excellent to try to convince people of the importance of at least, paying attention to that, read about this, and then implement this in their clinic, because this is the way to go in 2025.
I also want to highlight that this is a living tool. It's not something that is complete, right? you think about the innovation over the last year or two, even when this tool was being perfected, things are continuing to change. So we have to spend that time to maintain that tool. And that's something that the team is working on now. In terms of what was left out, one of the things that came to mind for me is we did pull in patients and perspectives, physicians from other countries. So that's something that I think was also important at the time. The uniqueness there is that depending on what country you're talking about, they may or may not have some of these treatment options to even be able to think about or give feedback on, but they were still included in the process.
Well, I think there is a lot of heterogeneity in the community. Some doctors are much more open to this approach. They will adopt it very quickly because they've been used to this in the past. Some others might be different in how they manage their interactions with their patients during the clinic. So I think it's a new spirit, a new mindset that we need to implement in the clinic.
I think, was it 100%, collaborative? Did we pull everybody in imaginable? No. But I think we did do a pretty good job of pulling the right people in at the right time.
You really need to capture a holistic approach of your patient, physically, mentally, every dimensions. So it takes time. I don't think that you can do this in a single clinic. This is a long process. And you discuss the involvement of other health professionals. I think it's nice, but let's be honest, there are very few centers where nurses, social workers are really on the front line and available all the time. That's not the case in many places. And also one of the difficulty today, also I have a new nurse in my center. So it will take some time for my new nurse to get updated with all the innovation. I don't think that my nurse will be ready in 3 months to engage in this kind of conversation about SDM, because, you really need to be aware and you should be trustable for a patient,
So, full disclosure, I am a mother of 2 adult sons with severe hemophilia. And I can remember doing clinic visits year after year after year. So can you tell me what the new innovations are? What do we have to look forward to? And crickets. So there wasn't a lot. And now I can only imagine what those conversations look like because it's just, it's phenomenal, the amount of innovation that, that we have in the bleeding disorders community.
From a practical standpoint, Cedric, talk a little bit about how, you're far ahead in terms of the implementation of SDM. And so talk a little bit about how like a clinic visit kind of runs. How has it really changed?
What's totally different today is that if I compare the situation nowadays to what it used to be, 100% of my patients are currently on prophylaxis. So that was not the case in the past. I couldn't manage prophylaxis in all the patients. And most of my patients have an ABR close to 0. So usually my clinic start, I review the current treatment option and then I want to make sure that my patients are not bleeding. Because if my patients are still bleeding, that means in my understanding of what we should try to achieve, there is a failure somewhere.
You don't just come and start doing shared decision making. One of the pillars of this process is patient education. And of course, the underlying pillar for patient education is knowledge. And I think that all of us would admit, as we're discussing these novel therapies, and not only gene therapy, but all of these novel therapies, we don't have a lot of long-term data. So is, this process sort of practically implemented? How is it hampered by the lack of knowledge that's really required for the patient and the physician to make good decisions? And the extent to which patients can be educated, how has that changed outreach to patients, patient education outreach?
I fully agree that patients should understand all these treatment options, but this is rather complicated. Again, what I try to do at each of my clinic, I try to explain my patients, what are the current innovations.
One of the things kicking around in my head as we have this conversation is, as a highly literate patient, when I go to my clinic visit, I'm gonna go to the WFH website. I'm gonna click on the shared decision-making tool. I'm gonna use it. I'm gonna inform myself and prepare as best as possible for that clinic visit. But truth be told, I don't know that I am representative of the average patient. So how are we ensuring that the education is reaching the people?
Being part of this community for so many years, one of the things that I learned early on was the importance of building relationships with other families, other community members, really building relationships at the local level. And one of the things that NBDF has done over the last 5 or 6 years is we've had an educational program called Candid Conversations. In the last couple of years, we've had it out at the chapters. And this, we bring together our physicians and our consumers that have been on different types of therapies, and to have that really honest, raw conversation about the concerns and, what was the process to figure out whether or not, you wanted to do a gene therapy trial. That's pretty profound to actually hear the different reasons. So I think people have learned so much through those conversations. And so that is something that I think we need to do more of.
What we do every year, that has been a little bit jeopardized by the COVID, but we used to invite all our patients during some sort of academic session. So they were invited in the evening. They had 90 minutes of short lectures on specific topic, and then they had plenty of time to discuss with a nice buffet. And that has a major impact. When you put all the patients together, they realize that all of them have different ambitions, treatment options, and so on. They interact with each other, they interact with the team, and it's a unique event that has a huge impact. It's not that easy to organize, but I think it's highly complementary to all.
We have seen somewhat of a decline in attendance to live events, at least here in the United States, and I would expect that that's probably more similar than not globally, but perhaps I'm wrong. Nonetheless, I think there's this idea that as treatments get better, as we get healthier, the need for community support goes down.
I'm convinced that artificial intelligence will help us. I'm confident that tools like chatbots, avatars, tools like this, specifically devoted to hemophilia, could help us in the future. Because honestly, during my clinic, I don't have 1 hour to offer to all my patients. I would love to do this because I love sharing interest, passion for that disease, but I don't have time.
I think the thing that we have to remember is our world today is very different than it was 5 years ago. People are more, kind of invested in TikTok than they are in, deep research. So how can we use those tools to make sure people understand what's going on and connect them with that?
So maybe additional tools could help, but it's a long process.
We also know that as consumers, we're not going to spend, 20 or 30 hours doing deep dive into medical journals, right? So we've got to figure out a way to get the right information to them in the right amount of time. So that's something that we've been working, really hard on the last several years to really make sure people understand these therapies. For the WFH tool, what's really cool about the tool is it's process-oriented. So it guides you through this process of learning. So it isn't just, helping you come to a decision. You have to learn along the way. And it really showcases that there's learning that's involved in decision-making.
It does appear, both in terms of what's published and in how you've spoken about this tool, that it's really geared to situations and environments, and therefore more higher resourced countries that do indeed have treatment options, right, to discuss. But ultimately, I imagine that the goal would be to broaden the use of this tool to low and middle income countries where there may not be that many options. And so I was just wondering what the plans might be to moving such a tool from, highly resourced countries to more limited resource countries.
I believe that this tool is fundamentally educational in nature, right? So while some countries don't have all of the options available to them, they may in the near future. And I think it's important that they spend that time and have the opportunity to spend time to learn about these things.
So I think this kind of tool will find its place in low-income countries, because you always have a patient with hemophilia. You always have to make some choice, some decision, in terms of lifestyle. How do you manage your life with that disease?
When consumers understand more about what's available, even if they don't have access to it, they can advocate with their countries, with their physicians, to get access to those medications.
And even if treatments are not available, there is always some kind of treatment. You could decide, do you go for a minimal prophylaxis, through the humanitarian aid program? Do you go in a trial locally? Do we invest more in physio, or approaches that do minimize bleeds or things like that?
The tool today has been translated into 6 or 7 languages. Please don't ask me to recite them, but they are on the website, which I think is so exciting. So I think it's much more accessible than folks may think. And so, I think that, another thing that I think we should talk about too is how that can be used as an advocacy tool.
The situation is improving globally, and I think this kind of tool will find its place, maybe with less choice, but there is always choice. And that can, because of the patient with hemophilia, sometimes you need to adapt your life, you need to set goals. Setting goals is important, and this kind of tool can also help you define, which goal do you select. Maybe in low developed countries, there are patients who have access to prophylaxis, but it's so complicated, especially venous access, and sometimes they get a little bit disappointed and they give up and things like that. And maybe that's time to have the discussion. We discuss minimal prophylaxis and the importance of having, these 1 or 2 infusions per week, and that could be part of the discussion and the decision. But again, education on both sides will be important.
And I think that's one thing that this tool does a nice job of, is expanding horizons and thinking about what might it look like if I had choice and if I had the ability to have a conversation with my provider. What could I learn? How could that change my life? So I think fundamentally, that's something that's also a piece of this.
There is something very original here. Has many times in history, hemophilia has really paved the way, because this concept of SDM is also applicable in many other disease area. But in my understanding, I think this is the only initiative that has been launched globally. There is no other disease that I know about where, a patient organization with plenty of other, stakeholders has been able to develop such a tool and make it accessible for the entire planet. I've never seen this. So I think we really need to value this. It's great, and I'm sure that it will be copied by other disease areas. I'm convinced of this.
Right now it's new. You don't really understand what the impact, you understand what the goals are, but you don't really understand what the actual impact will be on decision making, on patient care. And of course, there are a lot of feasibility issues that you've already addressed. So my question is there an ongoing evaluation? Is there ongoing data collection in the form of research, prospective observational data collection on issues of feasibility? And has there been some thought given to how impact will be measured in the implementation of this tool?
It's clear that we'll have to monitor and capture data to evaluate the impact of this. I'm not aware of any ongoing initiative at this stage, but I'm sure that with time, this kind of initiative will come. But yes, I think your suggestion is quite insightful. We'll have to do this in the future, although I'm convinced that it will have a positive impact.
It seems to me that an evidence base is an imperative in using this tool effectively. I mean, the more data you have, the more data you're able to, that the consumer has, that the lived experience expert has, that the physician and other providers have, the better the decision making. So how has that sort of influenced our general sort of research environment in terms of really understanding the importance of an evidence base and how we're going to go about deriving that evidence base that's really going to support this great tool?
Yeah, I don't have a specific answer to this. I need to brainstorm a little bit about this. But it's clear that, when you see what's happening currently in the treatment landscape, so we've had great success, but we also have had great failures recently. Some companies decided to stop the development of, maybe, that could have been different.
I'll just add in that the tool is being utilized quite nicely. I wish I had exact numbers for you, but surprising numbers of people are utilizing this tool. And, one other thing that I wanted to mention is that we're currently surveying patients and caregivers on the use of this tool. Mm-hmm. What did you think about it? How helpful was it? What more should be included? So we're asking those questions. And of course, that data will be gathered and will be, implemented to make that tool even better.
I think in terms of feasibility and impact, this survey may be a great way of beginning to get to some of those other questions of feasibility and incorporating them into your survey, at least to get some preliminary data that might be the basis for additional data gathering. That's great. That's great.
#MyHemophilia Real stories powered by Sanofi. It's time to consider the whole experience when it comes to managing hemophilia and change the conversation. Explore the full story at www.myhemophiliatruth.com.
So we've covered a lot of ground. We've talked about challenges, implementation, the need for data and refinement, et cetera. But after this conversation, as we're sitting here now at the end of it, what is most top of mind for you as you think about the future of shared decision-making? This tool itself, yes, but the concept more broadly and its implementation within hemophilia.
I think that SDM, especially with the new treatment options that we have, I think it will increasingly become, I don't know if the word is correct in English, the core of the clinic, because everything we will do during the clinic, or all the information that we need at the time of the clinic from, the health professional side or the patient side and his family side, I think that will be used to fuel this process and resulting in a treatment, that decision that will positively impact on the patient and his family until the next visit.
That's what comes to mind for me. It's a unique way of coming to a decision around treatment options, right? As Dr. Hermans mentioned, this could be the first of its kind. So I think that's something that we all have to get our heads around, having these collaborative discussions, learning how to enter into a really high quality debate so that you learn about different things. You challenge respectfully. So all of those things, I think, are going to be really important to the shared decision-making process. How we respect one another and how we value the input and the life experiences of both our patient community and our providers, and figuring out how to come together and benefit from that.
I see this as a great evolution. We discussed today, it's a paradigm change in terms of how you run your clinic. It's different, but it's achievable with the treatment options that we have, and I think it should be increasingly possible. But yeah, I see it as the new core of the hemophilia clinic for the future.
So I think that's the really cool thing about shared decision making.
Today, we took a look at the idea of shared decision-making between clinicians and patients who are together navigating a rapidly evolving treatment landscape. The SDM tool in continual development with the World Federation of Hemophilia provides an example of how we can tangibly implement shared decision-making. It also indicates the future of how clinics might operate with shared decision-making at their core. And while we're optimistic about shared decision-making, we also examined some of the barriers preventing efficacy and inclusivity. For shared decision-making to be effective, the average patient must be independently informed and health literate, which is proving to be a global challenge as attendance to in-person educational events is on the decline. Shared decision-making tools must also be translated for international audiences, not just in language, but with respect to which treatments are available where as well. As we know, many novel treatments are not globally accessible. The collaboration between doctor and patient is an ever-evolving one. As the treatment landscape complicates and expands, so does the doctor-patient relationship. Gone are the days of doctor knows best. If decisions are going to be shared, then education and advocacy must be shared as well. Though the impact of SDM is not yet quantifiable, it is clear that shared decision-making indicates a cultural shift in the future of hemophilia treatment. This is certainly an area to watch closely going forward. Thank you for listening to the Global Hemophilia Report, and thank you to Brendan Hayes and Dr. Cedric Hermans for their contributions. And if you liked this episode, check out the library of past episodes at globalhemophiliareport.com or search Global Hemophilia Report wherever you get your podcasts. This episode of the Global Hemophilia Report was made possible thanks to our featured advertiser, Sanofi. Special thanks to Dr. Donna DiMichele, our senior scientific advisor, and Keith Korneluk, our producer. This episode was written by Kay Vermeil and edited by Japneet Dhaliwal. We'll be back next month with another critical conversation. My name is Patrick James Lynch, and until then.
Sanofi is committed to bringing new perspectives and bold innovations to the global hemophilia community. Learn more about how Sanofi is committed to breaking barriers and supporting the community at redefininghemophilia.com.